All righty, we're ready to rock and roll.
Yeah, I was just about to say, looks like we have quite a few people. Maybe we should go ahead and get started.
All right, 7 a.m. We have an exciting day. Good morning, everybody. So today, the conference, are you running the conference today, Andrea? Is that what the plan is?
Yes, sir.
All right, so we have two speakers. You know, can you want to put the poster? We have Dr. Akinduro, who's going to be presenting a case that I think he did with Dr. Chachana. And then I think that we have Dr. Paola Mir presenting a case that we did together with Dr. JP Almeida. So at 7:30, I'm going to have to step out because I have another meeting with the NIH. So I apologize, but JP is here and the plan is to start with Dr. Akinduro this morning.
Yeah, that's right.
All right, we'll take it away.
I'm gonna stop sharing my screen. So.
All right. Everyone see my screen? Well,
Yeah, looks great. Thank you, Olu.
move this stuff out of the way. Okay. All right, let's get this party started. So this is a 46-year-old female. She had 2.5 years of strange pressure sensation in her left ear, some vertigo, long-standing tinnitus. She felt like her hearing declined, but she actually had a test which made it seem like her hearing was normal. She felt like she had a constant drill-like pain in the left side of her head, as well as the dizziness and kind of imbalance that I described. So from just this, Ange, what are some of the things that you may be thinking of, just kind of generally speaking?
Sorry, can you hear me?
Yeah.
So she has inner ear symptoms at this point, pressure sensation. I would thinking more of the ENT issue versus, and she has vertigo. I would like to question her on that to make sure it's peripheral versus central. Inner ear, cerebellar, posterior fossa. That's kind of my localization at this point.
Yeah, I think that's reasonable. Posterior fossa in the ear, but yeah, something like this. More, common things being common. If a person has symptoms like this, you're most likely going to think something like maybe vestibular neuritis, or see if she had any recent illness. But yeah, if you are thinking central versus peripheral, and if you are thinking central, like you mentioned, something maybe cerebellar or posterior fossa. So that's good. We'll keep going. The past medical history, nothing really remarkable. Maybe some migraines, hysterectomy. Her examination was also unremarkable, with good coordination and gait and full strength. So here's a head CT. So Dr. Lee, are you with us? Do you see anything strange on this head CT?
Hey, bud. Yeah, I'm on. Can you go back? I mean, obviously ventricular megaly, but go back to the brainstem. Go back. I thought some hyperdensity there. Yeah, right there. So central lesion. So at this point, probably need a MRI and with contrast as well to see if there's a tumor or a vascular lesion right there.
Okay. Yeah. So you said you're thinking potential tumor, you said a vascular lesion?
Yeah, I think that's a typical lesion for like burn, or some vascular lesions can be there, like right in the middle, right there.
Okay.
Yeah, I would definitely get an MRI to kind of better characterize that. And also regarding that hydrocephalus, I know the patient's asymptomatic, but this lesion may be causing compression of the fourth ventricle. But yeah, definitely MRI, further imaging for sure.
Okay, this is Dr. Gupta. Sorry to interrupt. Is that hyperdensity the only abnormality, or do you see more than just that hyperdensity?
Well, there's a hyperdensity lesion, and then there's a hypodense lesion around it. I feel like there's also a edematous. Yeah, but definitely, yeah, right there, yeah.
So basically
more
what you are
hyper-
not seeing, what structure are you not seeing here at all? What you should see normally here in the
like I
midline?
said, like the fourth ventricle, the aqueduct as well. So you should be seeing that, but you don't see that at all.
Okay. All right.
Okay.
So we don't see the fourth ventricle. Okay.
Yeah.
Right.
And here, actually, you can see, looks like the aqueduct may be expanded from this
Correct.
thing.
So even the fourth ventricle looks, actually it is expanded by something.
Yeah.
Okay.
And the lateral temporal horns are pretty big. Obviously, again, hydrocephalus.
Yeah. All right. Well, Dr. Lee, your wish is my command, and I have MRI for you, just as you asked. So on the left, we have a T1 post-GAD, and as you mentioned, there seems to be something filling the fourth ventricle here.
Oh yeah. So I see like heterogeneous enhancing lesion in the fourth ventricle right there.
Yeah, and like I mentioned, it's expanding the aqueduct there. You can see the fourth ventricle is expanded, as Dr. Gupta mentioned. Partially cystic lesion. And then here we have a flare. You see it's bright. And you do see a little bit of some transpendimal flow there as well, which kind of goes along with the mentioning of some hydrocephalus, which is what you would expect, of course, if the aqueduct and fourth ventricle were blocked. But she actually doesn't appear to be as symptomatic as you would possibly think she would be. And here, these are just snapshots, just to show a sagittal cut of the image there with the floor of the fourth ventricle and the roof. And then a DWI, just to, so Krishna, why do you think I'm showing a DWI?
So some of the, are you able to mute yourself? Some of the differentials for a lesion in this location would include a medulloblastoma, which may show some restricted diffusion. Alternatively, an epidermoid cyst could be considered. Also, a diffusion restricting lesion. This is hyper intense on DWI, suggesting it's not diffusion restricting.
Yeah, so it doesn't have that really strong restriction that you would expect for something like an epidermoid. So yeah, I think you mentioned some of the things on the list. Anything else? You mentioned epidermoid, you mentioned medulloblastoma.
Yeah, other fourth ventricular lesions. This is a contrast enhancing cystic heterogeneous lesion. An ependymoma, subependymoma is less likely given the presence of contrast enhancement. Hemangioblastoma is also differential. And then this patient has a history of ovarian cancer, if I remember. So fourth ventricular met, ovarian or uterine met is also a potential possibility for this lesion. Pilocytic astrocytoma rarely as well.
Yeah, I think that's reasonable. Yeah, she actually had, I think it was a ruptured ovarian cyst or something. So no history of cancer, but in general, yeah,
Okay, got it.
Or consideration really anywhere in the brain, but probably lower on the differential for this particular lesion, as you mentioned. So yeah, the only thing you didn't mention would be something like a corplex papilloma, but she is a little bit old. But medullo, of course, she's a little old for that. Epidermoid, not, because doesn't have the restriction we would expect. And also subependymoma you mentioned, but said would be lower because it does not enhance. Dr. Gupta, I don't know if you have anything else to add about the imaging or any of the differentials.
No, I mean, the thing is, once you go outside of this list, then you're really talking about very unusual entities. We have seen them, but it's not kind of something that you would mention up front.
Yeah.
So I think I'm reasonably happy with the list that you guys have talked about. I think the top differential on my side would be an ependymoma, the commonest tumor that looks like this. So I think that's totally reasonable. I mean, unusual tumors happen, but I think that's not how we sort of go about seeking the possibilities.
Yeah, very good point. So in general, anytime you have a tumor in this region, fourth ventricle, you always want to do neuroaxis imaging. just because of the possibility of drop metastasis. So that's something that we did, and she did not have any other anything else. So of course, preoperative clearance, and because of, well, one, she was symptomatic, and two, obviously she has a lesion that's obstructing the fourth ventricle, as well as the aqueduct, and some hydrocephalus. That in and of itself, of course, is enough, definitely enough of a reason to offer her surgical resection. So here I'll show the operative video. So actually, before I do that, let me see, Ala, what would you think of in terms of potential approach to this? I guess what would be the most likely approach that you would want to take?
Well, first we need to have the hydrocephalus, as you mentioned, so we'll probably go ahead with placement of an EVD at the time of surgery. If I'm not sure enough that I would approach or achieve a full or total cross resection, I would think of a VP shunt, but definitely my first would be an EVD placement. In terms of approaching the tumor, I would approach it through, there are different options. Can go there through a telovelar approach or a transfer-me approach. I would prefer going through a telovelar approach for that particular lesion.
As what we did, what minds think alike. So yes, we did a telovelar approach to the lesion. Here is our incision. So for incision, we basically did a midline kind of.
Was that a like from a movie or something?
Yeah,
I can do productions.
This is a
Star
movie.
Wars? Was it a Star Wars type of situation?
Star Wars edition of I Can Do It Productions.
Excellent.
So yeah, so we did a midline suboccipital craniotomy. When you're doing the incision, of course, you want to stay in that avascular plane. We identified C2 there, and then C1, as you can see right here. Here we drilled, I think we drilled 2 burr holes off of the midline of the keel, the thick keel in the middle. And then we turned used the foot plate to turn a bone flap. There, we just tried to bite down as much inferiorly and lateral as we could. So here, just to orient you, this is caudal, rostral. You see cerebellum there, and then the tonsils will be down here.
And did you take C1 out, Olu, or not?
I think we did take part of C. Yeah, I think we did take C1 in this.
Okay.
There you can see the tonsils. Ange, what vessel do you think that most likely is right there?
Sorry, I just I'm seeing this again here. I think it's the pica, but if you can orient me again, but I think it's the pica coming around the tonsillar segment, the tonsillar medullary segment.
Yeah, you said you want me to orient you again? So
yeah, but it looks like the tonsillar medullary segment of the pica.
Okay, yeah, just to orient you, caudal, rostral, and those are the tonsils that we're moving. Right there, you see, those are the tonsils coming down here. So yeah, I think you're most likely correct. And also, what is that? You see this stuff right here. What is that? That kind of frothy looking material.
Choroid plexus.
Choroid plexus, yeah.
Yeah. So when you're doing a telovelar approach, you want to identify the choroid plexus because I'll show some of the anatomy later, but the velum interpositum continues into the inferior medullary velum. There's a thin avascular plane between that, and you can use the choroid plexus to kind of help you identify it because it's going to be continuous.
And that's a very good point because you can open that up, also give you another half centimeter, sometimes even a centimeter of a space, which translates to a lot of space back there.
Yeah, and in this situation, the tumor had kind of already expanded that whole area. So that avascular plane had already been dissected for us. for the most part, but here we are opening it up a little bit more. So there, as you can see, that is the tumor of interest, grayish looking material. As most, I know we said ependymoma is the highest on our differential, and most of the intracranial as well as spinal ependymomas I've seen have all been pretty similar to this consistency. Sometimes a little bit more firm, rarely with some of the spinal ones, but for the cranial ones, especially the ventricular ones, are usually this similar consistency. So James, what do you think we need to be the most careful of in this region? Because
You gotta be careful of the facial colliculi. You don't want to give them like facial paralysis. I mean, there's all those other trigones too, but you don't want to hit any critical brainstem structures if that's what you're asking.
Yeah, the floor of the fourth ventricle is probably going to be the highest, the most expensive real estate in this region. So if we were to go, take our sucker and go right through the facial colliculus, what cranial
Abducens, but yeah, what other nuclei are below the facial colliculus? There's two, I think, for anyone.
Yeah, I'm asking you. So what below the facial colliculus, what is on the other side?
You mean the abducens?
Yeah.
Yeah, that's what I said, but I'm asking the other two that are inferior to the facial colliculus. There's two other ones for the floor of the fourth.
Yeah, that's okay. So here we're basically, so when you're trying to remove tumor off of the floor of the fourth ventricle, you want to be very, well, in general, if anything is stuck at all, you don't want to go chasing for it. So what you can do is have your sucker and have, take your finger off of the suction to where it's just barely, doing anything. And they just want to see if the tumor will just lift off of it, peel off of it. And luckily, the tumor did. And then what we did is we actually brought in an angled endoscope to look up into the aqueduct. And that's what you can see there, looking up into the aqueduct.
We can see that. So when you're doing these surgeries and you have these leftover blood products, you just irrigate them a lot because you don't want it to obviously clot right in the middle. So.
Exactly. Yeah, that's definitely a concern. You want to make sure that some of those blood clot products don't, migrate back up into the aqueduct. So that's one of the things we're also looking. We're looking for tumor, but also making sure there weren't any, big blood clots that we would need to go ahead and try to get rid of at that time.
And during the case, we try to block off any egress with those cottonoids and cotton products, just so we limit the blood to the cavity we're working in.
Yeah, that's a very good point. I think early in the case, we placed a cottonoid. Once we kind of reached around the rostral portion of the tumor and had the rostral portion exposed, I think we placed a cottonoid at that point to prevent any blood or tumor or anything from egressing backwards into the aqueduct.
And I guess the other question is, when you obviously work up for like drop meds, like you mentioned, but when you're resecting this tumor, are you ever worried about seeding, or is that not an issue for these?
Same as bleeding, you block off all the egresses of CSF space. So the inferior cistern, you block off with a cottonoid, you try to get above the aqueduct and block that off so that all the stuff is contained within the cavity.
Gotcha, thank you.
Did you guys find the origin of the tumor, the attachment?
I think so. It wasn't attached to the floor, like I mentioned. So if there was an attachment, I would have guessed maybe the inferior medullary velum somewhere along the roof.
And I think that for me, and I see Gabriel right there. I'm gonna ask to make a comment. For me, the most important thing, and I don't know if it was mentioned, is the patient position. Of course, the body habit is making a big difference. on that, whether the patient has a normal BMI, abnormal BMI. But I think that the patient positioning becomes a crucial, and I'm not quite sure that in that particular case, C1 was removed. Just seeing the craniotomy,
Yeah.
I would, because just for myself, I do remove, especially when the tonsils are that low, I do remove C1, and the patient is put in a very, very much of a tacting position, with the chin all the way, almost touching the clavicles, and to make sure that we're going to look up, especially for those attachments in that view all the way up. And when you do that, even with the microscope, if you angle a little bit, you can see all the way up to the aqueduct. So those are, some of the key position of the patient to be able to get around the tumor with minimal manipulation of the brainstem, ideally. And then, did you mention the neuromonitoring? What were you guys doing for neuromonitoring?
Yeah, we did have neuromonitoring. I'm pretty sure we definitely 7. We had bears, MEPs, SCPs, of course, but I think some of the lower cranial nerves as well. Not all the way down to like 12, but I know we definitely had 7 and 8, and then I think some of the 9, 10.
Yeah, we just did 7 and 8.
Okay, it was 7 and 8. Yeah, couldn't remember.
And I see, Gabriel, you want to comment? You were typing the same thing that I was thinking. Go ahead, Gabriel.
Yeah, I think that for this kind of tumor, always we have, before the surgery, of course, many different situations, and we should prevent. I heard Ala that mentioned that treat the hydrocephalus before would be an option. Many times when I don't see that big hydrocephalus, I try to wait, do the surgery, and wait for treat the hydrocephalus. But of course, during the surgery, we will be prepared for tap the ventricle just in case, leaving the occipital part free in order to do a burr hole if it's necessary. I don't do for all the times, but I be prepared for that. But always I try to not treat the hydrocephalus before, because many times, I've all mentioned, the CSF is coming down. The positions I try to do today more like a Concord position, trying to rotate a little bit the head and step outside of the patient. I work as a sitting position without being the sitting position, and I find that the best option for this kind of tumors. That is the main comments that I have today for that. So I don't use the midline, the cubitus pronus position behind the patient, but I step up at the side with the Concord position, and I use that position today.
Yeah, the Concord position is crucial. And I think, Fernando, you raise your hand. You want to comment as well? Go ahead, Fernando. Dr. Hakim.
Good morning.
Good morning.
Good morning. Nice to see you all again.
Same here, Fernando. Thank you.
When we, many years ago, when I was doing the residence, every time you saw a lesion in the fourth ventricle and you had hydrocephalus, the rule was treat hydrocephalus before going in the posterior fossa. But we know things have changed, and I agree with Gabriel. What we do is, if the lesion is big and is going down to C1, we always take down C1. Always have ready a burr hole or the occipital part if you're going to need to tap the ventricle. But what we try to do is take out the lesion, and if you see the aqueduct and the CSF moving freely, then the patient's not going to need a shunt, and we have treated the hydrocephalus by taking all the tumor out. That's the goal of the surgery, if we can do it. That's the way we see things. Thank you.
And I agree with that as well. And I think, Kai, that's why they didn't put, and if they usually prep Fraser's point right there. We're ready to rock and roll with the navigation. But once you open that aqueduct and you see the CSF coming towards you, I think that you're absolutely right. And I agree with Fernando and Gabriel. So good, beautiful. So is this, we've got the whole tumor out already? Polo, is that what I gathered right here?
Yes.
Beautiful resection. The brainstem is clean. The floor is clean. You think the attachment was on the roof? You know, if I understand it correctly, that's what you guys were looking with the endoscope. Anything else, Kai, from your side?
Oh yeah, so that's what we did. We didn't put a ventricular catheter because we thought we could treat the hydrocephalus from below. But if we didn't, we would put an EVD in. But yeah, and we chose the telovelar just because you don't go through parenchyma. Obviously, the telovelar allows you to look upwards a little bit more than a transvermian, so you're not going through parenchyma. So those are all the reasons why we chose the telovelar.
And then just let me ask Dr.
And sorry, one other thing. This patient was like really big, if I remember correctly, like a BMI of 40.
Yeah.
So positioning was challenging.
Yeah, that's what I was going to say. That's really what the challenge is. And Dr. Ravindran, I know that you mentioned the telovelar instead of the transvermian. What worries you about the transvermian approach? Just for our fellows and everybody, just teach them a little bit.
Cerebellar mutism.
Beautiful. And the patient is young, if I remember correctly. How old was this patient? Olu?
60, let me see.
Middle-aged.
Middle age.
Yeah, 46.
46, yeah. So cerebellar mutism is a potential complication. So everybody loves the approach of the, of the telovelar, avoiding going through the vermis. So good. So good resection. Let's see what the post-op scan shows.
Yeah, let me see. She did well. She didn't have any new deficits after surgery. Then we got a CT immediately after, and then an MRI later. And you can see the everything looks open there. And then MRI. See no obvious evidence of any tumor remaining. The aqueduct looks wide open.
Beautiful resection. You can see the vessels now right there outlining as you're going up and down.
Yeah, vessels still patent, as you can see.
Mm-hmm.
Yeah, so she did well. No new deficits, and run out of time. So just quickly run through a little bit of anatomy. So I won't be asking people, so we could get this done quickly. But here, this is kind of the structure that I mentioned that is continuous with the telochoroidea and forms part of the roof of the fourth ventricle. That's the inferior medullary velum. Here, as our excellent intern, Dr. Goyal, mentioned, was the pica that we saw. We also looked up into the aqueduct, as you can see there. Then here, have choroid plexus, which we identified, which kind of led us towards where we go. And like I said, telochoroidea is continuous with that. Here, superior peduncle, then we have brachium pontus, facial colliculus, as Dr. Lee mentioned. We have the hypoglossal triangle. This always used to confuse me when I was first starting out. Of course, hypoglossal you would think would be inferior, but the first, so you have, split everything into two halves. Above you have the facial colliculus, and below the colliculi that you see will be the hypoglossal first, and then the vagal triangle. And it just has to do with where the nuclei themselves are. And then area postrema and the obex. So now we'll get into.
Then let me just ask Andrea, what does the area postrema, the fact that Dr. Akinduro was hiding it, what does the area postrema do? And how does that affect the patient? Dr. Otamendi, are you there?
Vomit.
All right.
Nausea,
vomit. Yeah. They're very sick. Even though you saw that in the resection, they just, with the suction very gently, that's just going to be enough for this patient to be so sick from nausea, vomiting and stuff, but that's good. All right, thank you.
Dr.
Okay.
Gentile? Perfect.
For the pathology, you can see here, the blue arrows highlight basically cells kind of forming a line. that mimics the ependymal lining that you see within the ventricles. In addition to that, you see the area that's circled here, and you kind of get a idea of a perivascular pseudo rosette. If you go to the next slide, one interesting thing about this case is you can see all of this sort of clear whitish, almost maybe a faint grayish colored matrix in the background. This is sort of looks like mucin or mucoid change. It's something that's actually within ependymomas is most common with myxopapillary ependymomas. However, this case didn't have all the quite features, and it's very rare for those to be found anyplace else than the cauda equina, although you can have spread. So if you have one in the cauda equina and it's basically its capsule gets ruptured, you can have dissemination of that leptomeningeal dissemination. However, overall, I didn't favor that this is a myxopapillary ependymoma. And if we see within the cells, we don't see any mitotic activity, and the Ki67 labeling level is low. If we go to the next slide, the GFAP proves its glial nature, and you can see the EMA highlights that lining surface that I pointed out with the arrows. Additionally, we have some dot-like positivity that you can see within some of the cells. So this highly supports an ependymal tumor. Next slide. If we see neurofilament is negative, so neurofilament will highlight axons. So in infiltrating gliomas, you will have axons often intermixed within the tumor, demonstrating an infiltrative growth. This does not have that. And the LCM blue just highlights the mucin that I had mentioned. So at the end of the day with the diagnosis, and this is kind of important, in 2019, it made a difference because as myxopapillary ependymoma was considered grade 1, or I mean 2019 when this case was done, myxopapillary ependymoma was considered a grade 1. However, in the new updated WHO that literally just came out within the last month, but was anticipated for about a year, it's now considered a grade 2. So in some ways, it doesn't make as big of a difference as far as grading, but I thought this was most consistent with an ependymoma WHO grade 2, with a myxopapillary ependymoma being a consideration if subsequent imaging, demonstrated a cauda equina mass, or there was history that we didn't know about with the patient.
Very nice.
Beautiful, Mark. Beautiful, Dr. Genta.
Here, just a picture, just to kind of show everything that we talked about one more time, from a drawing as well as from an anatomical picture. So hopefully everyone learned some key points. I think that was a great case, good outcome, and great anatomy. So I don't know if Dr. Chachana or Dr. Q have any other comments.
No, this is beautiful. I love it. I think there was great comments from everybody. We really thank you.
All right, so I'll exit.
Let's see if we can move. I think, and JP,